Welcome back to the Explainer Masterclass, everyone. I'm absolutely thrilled to have you here for part 3 of our journey into shoulder arthroscopy and CPT coding mastery. Now, in part 2, we spent a lot of time analyzing the rotator cuff and those dynamic muscular stabilizers of the scapula. Today, we're shifting gears. We're going to master the static stabilizers, the cushioning bursae, the vital neurovascular pathways, and of course, the strict arthroscopic coding rules that govern the shoulder joint. If you're a medical coder or a healthcare auditor, these specific anatomical landmarks are exactly the keys you need to confidently unlock complex operative reports. Here is our quick game plan for today. We'll start with the bone and joint foundation, move into muscular stabilizers, tackle ligaments and bursae, do a quick clinical instability check, and wrap up with arthroscopic coding realities. Let's jump right in. Section 1. Our structural basics, the bone and joint foundation. To truly understand what a surgeon is modifying in the OR, we have to start right at the skeletal level. The shoulder joint is fundamentally a ball-and-socket synovial joint, and it's built upon the convergence of 3 primary intersecting bones: the humerus, the scapula, and the clavicle. Understanding exactly how these 3 pieces come together in 3-dimensional space is your first step to visualizing any arthroscopic procedure. Now, those bones don't just float in space, right? They articulate to form 4 distinct joints within the shoulder girdle. We've got the acromioclavicular joint, the glenohumeral joint, the sternoclavicular joint, and the scapulothoracic joint. Together, they create this incredibly complex, dynamic scaffold that gives our upper limbs that remarkable mobility. When a surgeon is dictating a procedure, they are meticulously navigating between these very specific joint spaces. Moving on to Section 2, the muscular stabilizers, driving strength and function. While bones provide the framework, muscles bring the movement and stability. There are 4 primary rotator cuff muscles connecting the humerus directly to the scapula: the supraspinatus, infraspinatus, teres minor, and subscapularis. All 4 take their origins straight from the scapula. And from a neurovascular standpoint, it's absolutely vital to know your nerve pathways here. The suprascapular nerve innervates the supraspinatus and infraspinatus, while the axillary nerve controls the deltoid and teres minor. These are prime anatomical anchors for your coding knowledge. Section 3. Let's lock things down with ligaments and bursae, our static stabilizers. Securing the entire joint, we have our primary ligaments. We've got the superior, middle, and inferior glenohumeral ligaments, along with the coracohumeral and transverse humeral ligaments, which do a great job securing the biceps tendon. And we can't forget the glenoid labrum and joint capsule acting as structural anchor points. But pay very special attention to the coracoacromial ligament, often just called the CA ligament. As we'll see in a minute, the surgical release of this specific ligament is a massive coder's hook for justifying an acromioplasty. Woven neatly between these ligaments, tendons, and bones are the bursa. A bursa is essentially a synovial fluid-filled sac. You have the subacromial, subdeltoid, subcoracoid, and subscapular bursa. Their entire job is to act as vital cushions, effectively reducing friction between those moving tendons and the hard bony prominences. When these get inflamed, you get bursitis or impingement, which usually leads a patient straight to the operating table for a decompression, setting you up to use codes like 29822 or 29826. Okay, Section 4. It's time for a clinical instability check to test what we just covered. Based on the ligaments and the complex joint structure we just mapped out, I want you to think about where the shoulder joint is most structurally vulnerable. What is the most common type of dislocation in the shoulder joint, and why? Take a quick second to picture the anatomy. If you guessed anterior dislocation, you are spot on. This is by far the most frequent type of dislocation we see clinically, and it typically happens when the arm is positioned in an excessive amount of abduction and external rotation. The crucial point for us is understanding the why behind it. When the arm is in excessive abduction and external rotation, that inferior glenohumeral complex is forced to serve as the primary restraint. Facing that maximal stress, the joint is highly susceptible to anterior failure. And here is a neurovascular bonus for you. When this dislocation happens, what nerve is most at risk? The axillary nerve, which innervates the deltoid. It, along with the anterior and posterior circumflex humeral arteries, sits highly vulnerable right in this exact anatomical space. Section 5. Arthroscopic coding realities. This is exactly where the anatomy pays the bills. Let's look at CPT code 29825. When a patient suffers from adhesive capsulitis, commonly known as a frozen shoulder, the joint capsule itself gets inflamed and restrictive. To treat this, the surgeon performs CPT 29825. They'll insert an arthroscope along with instruments to literally lyse or destroy those restrictive adhesions, restoring that free joint movement the patient desperately needs. Building directly on our earlier anatomy lesson, we turn to CPT 29826. Now remember, this is an add-on code. It dictates the decompression of the subacromial space with partial acromioplasty. Crucially, the code description explicitly requires the surgical revision of the acromion and the release of that all-important coracoacromial ligament, the CA ligament we highlighted earlier, to alleviate shoulder joint impingement.
Let's put this into practice with a real-world scenario. Look at this operative report for a 68-year-old female patient with chronic impingement. The surgeon detailed two absolutely key steps. First, an arthrocare wand was used to subperiosteally release a thickened CA ligament. Second, an arthroscopic burr was used to perform a subacromial decompression. Because the surgeon explicitly documented both the release of the CA ligament and the subsequent subacromial decompression, we can confidently, without a doubt, code 29826.
And I really want to draw your attention to the exact dictation used in that report. Quote, "The arthroscopic burr was used to perform a subacromial decompression working from lateral to medial, coplaning the undersurface of the acromion, removing any spurring," end quote. This exact phrase right here, coplaning the undersurface of the acromion, is the precise gold standard documentation that auditors and coders must hunt for in an operative note to definitively justify an acromioplasty. So this brings us to a pretty powerful realization. If simply knowing a ligament's name is just basic anatomy, but knowing its surgical release unlocks a specific CPT code, you have to ask yourself, how many other hidden coding clues are buried in your anatomical foundations? We've covered a lot today, from our static stabilizing ligaments and cushioning bursae to those vital neurovascular pathways like the axillary nerve. As you ponder that question and review your own operative reports this week, get ready for part 4 of our masterclass, where we are going to tackle diagnostic arthroscopy fundamentals and those tricky surgical inclusion rules. But until then, decode healthcare with Harshal.